This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2019, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is When Less is More. Dr. Dean Hess is a registered respiratory therapist and fellow of the AARC. He is a respiratory therapist at the Massachusetts General Hospital and teaches in the MS in Respiratory Care Leadership Program at Northeastern University in Boston, Massachusetts. Dr. Hess is also the managing editor for Respiratory Care Journal. Dr. Hess discloses relationships with Philips Respironics, Ventec Life Support, Daedalus Enterprises, McGraw-Hill, Jones and Bartlett, and Up to Date.
So the topic of this presentation is when less is more. These are the topics that we are going to discuss in this presentation. We will be talking about non-invasive respiratory support. We will be talking about lung protective ventilation. We will be talking about oxygen administration. We will be talking about ventilator liberation. I think each of these is an example of where doing less is more beneficial for our patients. There are also a number of categories where I might say when none is more. And I won't be talking about those in any detail today, but they include things like incentive spirometry, IPPB, airway clearance when there are no retained secretions, inhaled bronchodilators when there is no bronchospasm. But today we're going to talk about when less is more rather than these topics about when none is more. So the first thing we're going to talk about is non-invasive respiratory support. Shown on this slide are three forms of non-invasive respiratory support. They include non-invasive ventilation, continuous positive airway pressure, or CPAP, and high-flow nasal cannula. And we can see that with non-invasive ventilation, we apply an inspiratory pressure, which is greater than the expiratory pressure. That produces respiratory muscle unloading and results in a lower pleural pressure change, and it augments the tidal volume. With continuous positive airway pressure, we apply a continuous pressure to the airway, typically with a face mask. That will provide some benefits as a result of the pressure. However, the patient is responsible for all of their work of breathing. They are responsible for producing the pleural pressure change with their respiratory muscles that will generate a tidal volume and a minute ventilation. With high-flow nasal cannula, as we'll see in a bit more detail in a minute, we also have a small amount of continuous positive airway pressure, although typically not as much as we might get with CPAP or non-invasive ventilation. And for mechanisms that we will discuss with high-flow nasal cannula, there is also some onloading of the patient's work of breathing, so the pleural pressure changes are reduced, and there may be some augmentation of tidal volume. There's been a lot of clinical and academic interest in high-flow nasal cannula over the last 5 to 10 years or so. This is a cartoon illustration of a typical setup for high-flow nasal cannula. So there is some form of air, oxygen blending or a blender to mix air and oxygen. there is a flow meter that can accommodate high flows of gas, typically up to 60 liters per minute. And then what really allows high flow nasal cannula to be used clinically is the heated humidifier and the heated circuit. We could not apply 60 liters per minute through a typical nasal cannula because that dry gas would be extremely uncomfortable for our patients and would not be tolerated. So what makes the high flow, up to 60 liters per minute with a high flow nasal cannula, tolerable for our patients is that the gas is warmed and humidified. And then there are nasal cannula that are designed specifically to be used for high flow nasal cannula. Shown on this slide are some of the commercially available cannula for high flow nasal cannula therapy. The point that I want to make from this slide is that we really have no evidence that I'm aware of that one of these is superior to the other. So an area where I think that some important work could be done is to study these devices clinically to help to inform us as to whether there is one style of high flow nasal cannula that may be better or worse than others, or perhaps we learn that they are all comparable. Now, when I look at these high flow nasal cannula that are commercially available, I have grouped them into two types. There are large bore cannula and there are small bore cannula. The large bore cannula typically has a larger diameter to accommodate high flows up to 60 liters per minute. And with these, there's a partial occlusion of the nares, which facilitates a CPAP effect. So the larger bore cannula and the high flow together results in a small amount of CPAP, and in some cases a modest amount of CPAP, as we'll see in a few minutes. The smaller bore cannula has a much more narrow lumen, and as a result of that, there is a high velocity nasal insufflation. So there's a high velocity of gas that is exiting the cannula. These are typically used at lower flows, 25 to 35 liters per minute. It has been suggested that the high velocity may result in better clearing of the carbon dioxide from the dead space of the upper airway. But I put a question mark there because there still needs to be work done to support that that is the case. There might also be less precise control of FiO2 because the high velocity of gas exiting the cannula could result in some room air entrainment. Again, I would make the point that we have precious little evidence to support that one is better than the other, and we need to have additional work done to help to inform us about that. Illustrated on this slide are some of the mechanisms, some of the physiologic mechanisms whereby high flow nasal cannula might be clinically beneficial. First of all, the gas is fully humidified, so the inspired gas of the patient is fully humidified. That contributes to comfort for the patient. The humidification might also facilitate better airway clearance. The high flow of gas coming into the nose, if you follow the yellow arrows on the cartoon, that high flow of gas will effectively flush the upper airway dead space. So for you and I, as we are breathing now, at end exhalation, there's carbon dioxide in our upper airway, and then on the subsequent inhalation, that CO2 in that gas is the first gas to reach the lower respiratory tract and the alveoli of the lungs. By flushing the upper airway dead space of that carbon dioxide, then there should be a lower tidal volume requirement, a lower minute ventilation requirement, a lower respiratory rate requirement, because the inspired gas is completely carbon dioxide free. If we introduce 50 or 60 liters per minute of flow into the pharynx, then when the patient inspires with an inspiratory flow of 30 or 40 or 50 liters per minute, they do not need to breathe in through the upper airway, which has a lot of resistance. So in that way, the high-flow nasal cannula will decrease inspiratory resistance because the patient is breathing from the high flow rather than needing to draw flow through the high-resistance upper airway. And in that way, this may reduce the patient's work of breathing. There is a small CPAP effect because that high flow being introduced into the pharynx is opposing the patient's exhalation, and by opposing exhalation, we may get a small CPAP effect. And then finally, the very high flow minimizes the amount of room air dilution, and in that way, we can administer a more precise FiO2. This was illustrated very nicely in this paper published in 2017 related to high-flow nasal cannula. Across the top of this slide, again, you can see the 5 mechanisms for benefit of high-flow nasal cannula that I illustrated on the previous slide. And then this slide illustrates a number of reasons why that may result in improved clinical outcomes. And we now have studies reporting better clinical outcomes, and we'll talk about a few of those in just a minute. There have been studies that have looked at the physiologic effects of high-flow nasal cannula. So the slide on the panel on the left of this slide is illustrating esophageal pressure changes. And as you can see in this group of patients who was studied, the esophageal pressure changes were lower with high-flow nasal cannula. And what that means is that the patient's work of breathing should be better. So a lower work of breathing, less respiratory muscle effort required with the use of high-flow nasal cannula. In the center panel, we're looking at minute ventilation, and as you can see with high-flow nasal cannula, there is a significant reduction in the minute ventilation requirement. Why is that? Well, most likely because of the flushing of carbon dioxide from the upper airway, meaning that less ventilation is necessary in order to maintain the same arterial PCO2. And then in the right-hand panel, we're looking at lung volume, and you can see a significant increase in lung volume with the use of high-flow nasal cannula. This most likely is the CPAP effect of high-flow nasal cannula, increasing lung volume. So then the mechanisms, the physiologic mechanisms for high-flow nasal cannula that I showed in the previous 2 slides have data to support those effects. This is a paper published a few years back in Respiratory Care. So what we're looking at here is lung volume in the dark color, black on the bottom, breathing frequency or respiratory rate in the red color, and airway pressure in the green color. And we're looking at each of those as a function of the flow from high-flow nasal cannula. In this study, they used flows up to 100 liters per minute. I would not recommend using flows that high, but it nicely illustrates that with an increase in flow from the high-flow nasal cannula, there is a decrease in respiratory rate. That is likely the result of clearing of carbon dioxide from the upper airway. There is an increase in lung volume. That's the CPAP effect. And there's an increase in airway pressure, which is Again, the CPAP effect. And the other thing that you can see from these data is that there is about a 1 centimeter of water increase in pressure, increase in CPAP, if you would, for every 10 liters per minute of flow. So I think a useful thing to think about at the bedside with high-flow nasal cannula is that as we increase the flow, there will be an increase in CPAP effect of about 1 centimeter of water for every 10 liters per minute. So if we set the high-flow nasal cannula at 50 liters per minute, we might expect that we would get around 5 centimeters of water of CPAP. Now, there was a lot of enthusiasm around the use of high-flow nasal cannula when this paper was published in the New England Journal of Medicine in 2015. And what we're looking at here is the effect on survival with the use of high-flow nasal cannula, conventional oxygen therapy, and non-invasive ventilation in patients with acute hypoxemic respiratory failure. As you can see, survival was the highest, was the best with high-flow nasal cannula, and interestingly enough, survival was the worst with non-invasive ventilation. And in fact, there are a number of recommendations about not using non-invasive ventilation for things such as ARDS, and these data would support that. But most relevant to the discussion on this slide is that there is a survival benefit associated with the use of high-flow nasal cannula in patients with acute hypoxemic respiratory failure. So in addition to those physiologic benefits that I talked about, there is also evidence that this therapy will afford a survival benefit for our patients. There are other groups of patients where benefit has also been shown. This study looked at the use of high-flow nasal cannula in patients at risk for extubation failure, showing that with the use of high-flow nasal cannula, there was a reduced need for non-invasive ventilation and a reduced re-intubation rate with the use of high-flow nasal cannula. So another place where we might think about using this therapy is in patients, particularly those patients with hypoxemic respiratory failure who are at risk for re-intubation after we take out the endotracheal tube. Now, we talked about high-flow nasal cannula as a form of non-invasive respiratory support. Let's talk for just a few minutes about non-invasive ventilation, another form of non-invasive respiratory support. We now have a number of studies that support the use of non-invasive ventilation in appropriately selected patients, and as was shown in this meta-analysis, that non-invasive ventilation in appropriately selected patients reduces mortality. It affords a survival benefit for our patients. And the patients who are most likely to benefit are those with COPD exacerbation, those with acute cardiogenic pulmonary edema, those who develop postoperative acute respiratory failure, and for prevention of post-extubation acute respiratory failure. And what I show in the red box is the number needed to treat, the number of patients who we need to treat with this therapy, non-invasive ventilation, in order to save a single patient's life. And you can see the numbers are quite low, in the teens. So we only need to treat a few patients with non-invasive ventilation to save patients' lives in appropriately selected patients. There were some guidelines that were published in 2017 to help to inform the use of non-invasive ventilation. The authors of these clinical practice guidelines recommend that non-invasive ventilation should be used for COPD exacerbation, acute cardiogenic pulmonary edema, postoperative respiratory failure, chest trauma with acute respiratory failure and to prevent post-extubation respiratory failure in high-risk patients. So there is robust evidence to support the use of non-invasive ventilation with these diagnoses. The authors also recommended that non-invasive ventilation should not be used for hypercapnia without acidosis in patients with COPD exacerbation, to prevent post-extubation respiratory failure in patients who are not at high risk for reintubation, and in established post-extubation respiratory failure. The authors also made no recommendations for the use of non-invasive ventilation for acute respiratory failure due to asthma or for de novo acute respiratory failure, what we will often call ARDS. And the reason why no recommendations are made for these diagnoses is simply because there is not a very robust evidence base upon which to base a recommendation. Now, interestingly enough, there are places where we might see a role for either high-flow nasal cannula or for non-invasive ventilation. And one place where we might think about using both of these therapies is in the patient who is being intubated. So a patient who fails non-invasive ventilation or who fails high-flow nasal cannula and needs to be intubated. In this study, and there are several others like this, they describe an approach where patients are placed on non-invasive ventilation while the team is preparing to intubate the patient, and then the non-invasive ventilation is stopped and is actually switched to high-flow nasal cannula, and the patient receives high-flow nasal cannula during the intubation itself, and then the patient is attached to an invasive ventilator. Now, some of you, like me, may think this is an awful lot of equipment to drag into a patient's room for an intubation. The equipment for high-flow nasal cannula and non-invasive ventilation and then invasive ventilation. And I can tell you that there are now at least 2 ventilator manufacturers who I'm aware of who have ventilators who can provide high-flow nasal cannula, non-invasive ventilation, and invasive ventilation all within the same machine. And I would predict that in the near future, we will see that many ventilators will be multifunctional in that way, so we can use the same machine whether we're providing non-invasive respiratory support or invasive respiratory support. Now let's move our discussion to lung protective ventilation. This, I think, is another example of when less is more, when we do less and it results in better patient outcomes. To begin this study, let's look at the ARDS network study published back in 2000, in which patients were randomized. These were patients with ARDS who were randomized to receive either a tidal volume of 12 milliliters per kilogram of ideal body weight or a tidal volume of 6 milliliters per kilogram of ideal body weight, and also targeting in the lower tidal volume group a plateau pressure less than or equal to 30 centimeters of water. I would point out here that they used good old-fashioned volume control ventilation in this study. There was no new fancy modern ventilator mode. So all they did was on volume control ventilation, set the ventilator for a tidal volume of 12 mLs per kilogram or a tidal volume of 6 mLs per kilogram. Well, what did they find? I think to the surprise of many at the time, the lower tidal volume, 6 mLs per kilogram of ideal body weight, resulted in a 25% reduction in mortality. In other words, a strong signal for benefit, for survival benefit, using the lower tidal volume. And this translates into a number needed to treat of only 12 patients. So for every 12 patients who we treat with a lower tidal volume rather than a higher tidal volume who have ARDS, will save an additional patient's life. So we have really strong evidence dating back to the year 2000 that we should be using lower tidal volume ventilation in adult patients with ARDS. So are we doing it? Well, sadly, not as well as we should. This is an epidemiologic study published in JAMA in 2016, collecting data from ICUs in 50 countries around the world, including the United States. And what did they find? 16 years after that seminal ARDS network study supporting lower tidal volumes, fewer than 2/3 of patients with ARDS received a tidal volume less than or equal to 8 mLs per kilogram of predicted body weight, or ideal body weight, if you would. So I say, shame on us, all of us who work in the ICU, all of us respiratory therapists who work in the ICU. There is a lot of room to improve here. We have data for a therapy that saves patients' lives, and we can ask ourselves, why aren't we doing this? Also in this study, the plateau pressure was only measured in 40% of patients. So how are we going to know if the plateau pressure is less than 30 centimeters of water if we don't even bother to measure it? So again, shame on us. And in the United States, it is we, respiratory therapists, who are responsible for measuring the plateau pressure. So we have evidence where less is more. Using a lower tidal volume affords a survival benefit for our patients. And unfortunately, we are not doing that universally. Now, some people will say, and I've heard this said many times, well, you know, the ARDS network study, that was for patients with ARDS. A lot of my patients don't have ARDS, so it doesn't matter. Well, it does matter. And in fact, this is a study looking at lung protective ventilation, tidal volume, and its effect on outcome in patients without ARDS, patients who do not have ARDS. And what they found was that as the tidal volume increased, there was an increase in pulmonary complications. So this looks like a dose-response relationship to me. The higher the tidal volume, the greater the number of pulmonary complications. Again, my theme is here, less is more, less is better. Also in this study, looking at mortality, you can see that the mortality goes up as the tidal volume goes up, and these are patients who do not have ARDS. So then what's my point? Well, my point is that we should be using lung protective ventilation, low tidal volume ventilation in all of our mechanically ventilated patients, whether they have ARDS or not. We should also be using lower tidal volumes in our patients receiving non-invasive ventilation. I suspect that many of you do not pay as close attention to the tidal volume during non-invasive ventilation as you might during invasive ventilation. But these data, published back in 2016 in Critical Care Medicine, suggest that we should be monitoring tidal volume as closely in patients on non-invasive ventilation as patients on invasive ventilation. Because what we can see here is that the risk for failure of non-invasive ventilation is higher in patients who are receiving higher tidal volumes. So even during non-invasive ventilation, we should be monitoring the tidal volume, targeting lower tidal volumes. Higher tidal volumes are associated with failure of the therapy. Now, what about PEEP? So with PEEP, I will not say less is more, and I will not say more is less. I won't say either way. With PEEP, I think what is important is that we get it right, and that we get it right for an individual patient. With PEEP, Let's imagine we have a patient, for example, the patient in the blue rectangle receiving 6 mLs per kilogram of tidal volume, and the PEEP is 10 centimeters of water and the plateau pressure is maybe 22 centimeters of water. So if we increase the PEEP, there are two kinds of responses that might occur. In one case, we increase the PEEP from 10 to 15 centimeters of water. The patient does not have lung recruitment. We can see here in the orange box, the PEEP goes up, the plateau pressure goes up a lot, and the compliance goes down, and the driving pressure goes up in this case. Because here, when we increase the PEEP, we do not get alveolar recruitment, and the result is that we end up with alveolar overdistension. So here, the increase in PEEP results in an injury which is greater than the benefit. But now imagine another patient where we turn the PEEP from 10 to 15 centimeters of water. This is the yellow box. And now when we turn up the PEEP by 5 centimeters of water, maybe the plateau pressure only goes up by 1 or 2 centimeters of water. So now the compliance may have gotten better, the driving pressure may have gotten better, there is more alveolar recruitment, and in this case, we might argue that the benefit of the higher PEEP exceeds the potential for injury. So with PEEP then, we need to, I believe, in an individual patient, test the response to an increase in PEEP, and if we get a deleterious effect, use lower PEEP. If we get a beneficial effect, use higher PEEP. This is a meta-analysis published in JAMA a few years ago that suggested that the benefit of PEEP may depend upon whether the patient has moderate or severe ARDS or mild ARDS. And what they showed in this paper was that the survival was greater in patients with moderate or severe ARDS if they received higher PEEP. However, in patients with mild ARDS, the survival was better in patients who received lower PEEP. So this then may suggest that in patients with ARDS who have a PO2-FiO2 ratio of 200 to 300, we might use lower levels of PEEP, that's mild ARDS. In patients who have a PO2 to FiO2 ratio less than 200, to use higher PEEP because those patients have moderate to severe ARDS. This is another way that we may look at it. This, I think, is a very provocative paper published back in 2015, where the authors suggested that maybe best PEEP does not exist because what we should be striving for is better PEEP as a reasonable compromise among oxygenation, hemodynamic status, and intratidal volume opening and closing, or recruitment, de-recruitment. And these authors suggested that in patients with severe ARDS, patients where the PO2-FiO2 ratio is less than 100, to use 15 to 20 centimeters of water of PEEP. And in patients with moderate ARDS, PO2-FiO2 of 100 to 200, to use a PEEP of 10 to 15 centimeters of water. And in patients with mild ARDS, PO2-FiO2 ratio greater than 200, to use 5 to 10 centimeters of water of PEEP. In other words, to use lower levels of PEEP in patients with milder disease, use higher levels of PEEP in patients with more severe disease. And the recommendations from this group, I think, are very attractive because this is very easy to implement in the ICU. So using PEEP so that we get the right level for an individual patient. And here, sometimes more is better and sometimes less is better. There were some clinical practice guidelines published in 2017 related to mechanical ventilation of patients with ARDS. And this group recommended a strong recommendation for the use of tidal volumes of 4 to 8 milliliters per kilogram of predicted body weight or ideal body weight and maintaining the plateau pressure less than 30 centimeters of water. This, again, is, I think, an area where we as respiratory therapists can make a difference because we are the ones setting the tidal volume. We are the ones who are monitoring the plateau pressure. There were conditional guidelines for the use of higher PEEP in patients with moderate or severe ARDS, and that's what I talked about at the previous few slides. And they also had a conditional guideline for the use of recruitment maneuvers in patients with moderate or severe ARDS. I'm really not going to say anything more about recruitment maneuvers in this presentation. So now let's turn our attention to oxygen administration. I think this is another area where less is more, and we have evolving evidence to support that less is more when it comes to oxygen administration. This, I think, is a very interesting study that was published in British Medical Journal back in 2010, where they looked at the effect of oxygen on mortality in patients with chronic obstructive pulmonary disease, or COPD, in the pre-hospital setting. And they call this high-flow oxygen. This is really not high-flow nasal cannula, as we had talked about previously in this presentation. They're talking about delivering oxygen by a non-rebreathing mask or a simple mask, or at flows of, say, 4, 6, 8, 10 liters per minute by nasal cannula. So it's really not high-flow nasal cannula as we had talked about previously. So what did they do here? Well, in the pre-hospital setting, they randomized patients with COPD into two groups. In one group, the paramedics administered oxygen to target an oxygen saturation of 88 to 92%. In the other group of patients, they just allowed the paramedics to administer whatever amount of oxygen they wanted. So if the paramedics wanted to deliver high concentrations of oxygen, which was often the case, then they did that. Well, what did they find? They found a significant reduction in mortality in patients who had their oxygen saturation targeted to 88 to 92%. And before we talked about number needed to treat for benefit, here we will talk about number needed to treat for harm. And what they found was that for every 14 patients who received the uncontrolled higher amounts of oxygen, one additional patient died. So here there is a strong signal for a survival benefit for patients with COPD having their oxygen saturation targeted to 88 to 92%. Well, what about other types of patients? What about patients with acute MI? So for my entire career, and in fact for many years, I taught patients with acute MI, you put them on a non-rebreather. You give them a lot of oxygen. Well, it turns out that is not to the benefit of patients. And in fact, in patients with acute MI who are not hypoxemic, if we administer supplemental oxygen, that can produce harm. This is just one such study showing that in patients who received oxygen with acute MI, their troponin release was greater than in patients who did not receive oxygen therapy. So these kinds of data suggest that in patients with acute MI, we should only be administering supplemental oxygen if the patient is hypoxemic, if the patient has a normal oxygen saturation. The administration of oxygen does not help, and in fact, it harms. What about patients in the ICU? Well, this study, published in JAMA 2016, randomized patients into two groups. One group of patients received what they called the conventional approach to oxygen administration, where they allow PO2s as high as 150 millimeters of mercury or oxygen saturations as high as 100%. I think that's what happens commonly actually in the ICU. Who doesn't like to go home at the end of their shift and all of their patients have an oxygen saturation of 100%? That feels good as a clinician, but it might not be the best thing for our patients. So one group of patients received conventional oxygen administration. The other group of patients received a more conservative approach, targeting a PO2 of 70 to 100 millimeters of mercury or an oxygen saturation of 94 to 98%. And look at the difference in mortality. So note that if we look at mortality in these patients, the mortality in the patients who received the conventional approach to oxygen was nearly twice that of the more conservative oxygen administration group. So this suggests to me that in patients in the ICU, we should be targeting a more conservative approach to oxygen administration. Less is more here, because the lower target, the more conservative target for oxygen administration results in a lower mortality. And in fact, in this study, the mortality was about half in the patients receiving the more conservative, less is more approach. This has also been studied in patients with ARDS. In this study, they used a clever research design. I won't go into the details of that. Suffice it to say that what they found was that in patients with ARDS, the higher the amount of oxygen support that the patients received, the more was the amount of excess oxygen, the greater was the mortality. So in other words, patients with ARDS receiving excessive oxygen resulting in hyperoxemia were more likely to die. And that was true whether the patients had mild ARDS, moderate ARDS, severe ARDS. Excessive oxygen, using oxygen administration, targeting excessive levels of arterial oxygenation resulted in a greater mortality. Less is more. Some of these studies were put together with a number of other studies in this meta-analysis published in Lancet in 2018, where when they compared a more conservative approach to oxygen therapy in patients in the ICU to a more liberal approach to oxygen therapy in patients in the ICU. If we look at survival, which is on the y-axis, you can see that the survival is significantly better where a more conservative approach was taken to oxygen administration. So the point here again, less is more. So way back in the ARSNet study that was published in 2000, they targeted in patients with ARDS a PO2 of 55 to 80 millimeters of mercury, an oxygen saturation of 88 to 95%. I think that these are very reasonable targets for oxygenation in the ICU, and now we have accumulating evidence that targeting oxygen levels in excess of this may contribute to mortality. So if we look at this in relation to the oxyhemoglobin dissociation curve, what I've placed in yellow, an oxygen saturation less than 88%, a PO2 less than 55 millimeters of mercury, might subject our patients to harm due to hypoxemia. So certainly we want to avoid that. But as I also show in this slide, in the orange shaded area, a PO2 greater than 80 millimeters of mercury or an oxygen saturation greater than 95% might also contribute to harm. This is a paper we published in Respiratory Care a few years ago looking at this issue of excessive FiO2 and outcomes in patients with acute lung injury. And I like some of the authors, I like all of the authors' conclusions here, but in particular, the part that I have underlined, which says that optimal titration needs close monitoring. And here we're talking about optimal oxygen titration needs close monitoring and may be a potential for greater participation of us, respiratory therapists. So we as respiratory therapists should be paying attention to this at the bedside. And not only should we be trying to avoid hypoxemia, we should also be attempting to avoid hyperoxemia, because we have accumulating evidence that hyperoxemia may be harmful. So now let's talk for a few minutes about ventilator liberation. Again, this is another area of less is more. So to the extent that we can get our patients liberated from the ventilator sooner, less mechanical ventilation, maybe better outcomes. A point here that I want to make is that there's no such thing as weaning. So we're not trying to wean the patient off of the ventilator. What we should be trying to do is identify when the patient is likely ready to be liberated from the ventilator, doing a spontaneous breathing trial, and then extubating the patient if the patient can breathe adequately without the support of the ventilator. So then how do we know if a patient is ready for a spontaneous breathing trial? And I would submit to you that a lot of this is just good common sense. So first, that there is some evidence for reversal of the underlying disease process, that the patient is getting better, that there is adequate gas exchange. I think we will all agree that if the patient's oxygen saturation is 85% and the patient's on 20 of PEEP and 100% oxygen, we're not going to try to liberate that patient from the ventilator. That the patient is hemodynamically stable. Again, this makes sense. Patients on the ventilator, hypotensive, on 3 pressors, that's not the kind of patient we're going to try to liberate from the ventilator. And then that the patient is able to initiate an inspiratory effort, which has a lot to do with how sedated the patient is. So in many ICUs now, we will first do a spontaneous awakening trial where the nurse will stop the sedation, and that then increases the likelihood that the patient can make an inspiratory effort, and then the respiratory therapist will proceed with a spontaneous breathing trial. More on that in a minute. Well, what about so-called weaning parameters? Is there any role for those in the modern adult ICU? There have been a number that have been described over the years, and I would submit to you that none of them is very helpful. It has been shown now in, I believe, a number of studies that weaning parameters are just not very predictive. And I think there are much more important things that you and I as respiratory therapists can do at the bedside than weaning parameters that really don't help very much to determine if a patient's ready for extubation. So then what about the rapid shallow breathing index or the rate tidal volume ratio? So this is perhaps the best of the weaning parameters, but it's also not very good. And this is a very interesting study done a number of years ago now, in which patients were randomized to have their rapid shallow breathing index measured and used to determine when the patient was ready to come off of the ventilator, or if the rapid shallow breathing index was measured but was not used in the decision making. Essentially what happened in this study was that the respiratory therapist in the morning did a rapid shallow breathing index on all of the patients, and then at rounds in half of the patients they told the team what it was, and then the other half of the patients they did not tell the team what it was. And look at what happened. The weaning time was significantly shorter in the group where the rate tidal volume ratio, or the RISB, was not used. So patients came off the ventilator more quickly if this weaning parameter was not used. And there was no difference between the groups in things like extubation failure, unplanned extubations, hospital mortality, and so forth. So this study then would suggest that even the rapid shallow breathing index is not very useful. And I can tell you that in my practice, I have not used it in many years because I think that it is not as helpful as we once thought that it was. This is a very important study published in The Lancet a few years ago, looking at the efficacy and safety of a paired sedation and ventilator weaning protocol for mechanically ventilated patients in the ICU. And in this study, what was evaluated was the use of sedation per whatever was the usual care in the ICU, with spontaneous breathing trials done by the respiratory therapist, or to first do a spontaneous awakening trial where the sedation that the patient was receiving is stopped, and then if the patient tolerates the spontaneous awakening trial, if the patient tolerates having their sedation stopped, then the respiratory therapist does the spontaneous breathing trial after the spontaneous awakening trial. And what did they find? Well, they found that in the patients who received the spontaneous awakening trial, stopped the sedation, immediately followed by the spontaneous breathing trial, the wake up and breathe group, those patients had more ventilator-free days, come off the ventilator sooner, were discharged from the ICU sooner and from the hospital sooner, and in addition to that, had a lower mortality. Less is more. Stop the sedation. Do a spontaneous breathing trial. The patient tolerates the spontaneous awakening trial and the spontaneous breathing trial. Take out the endotracheal tube, unless there's some other contraindication to taking out the tube, such as if there's upper airway pathology. So then how do we do the spontaneous breathing trial? There may be a little bit of benefit for the use of low levels of pressure support, 5 to 7 centimeters of water, or tube compensation over the use of a T-piece, but the benefit, as I indicate on the slide, is slight. There's not a real big benefit for that in most patients. We can do the spontaneous breathing trial while the patient is still attached to the ventilator. If we set the pressure support to 0, and if we set the PEEP or the CPAP to 0, or if we set the pressure support to 5 and the PEEP or CPAP to 0, then we can do essentially the equivalent of a T-piece trial without removing the patient from the ventilator. 30 minutes is probably adequate for a spontaneous breathing trial. Most patients and many patients, we do not need to do a prolonged spontaneous breathing trial. And I would recommend that you avoid doing spontaneous breathing trials with a CPAP of 5 centimeters of water, which I know is commonly done around the country, but I would urge that you do not do a CPAP spontaneous breathing trial, because that can produce false positives in patients with COPD and congestive heart failure. So what I mean by that is doing the spontaneous breathing trial on a CPAP of 5 might mean that the patient passes the spontaneous breathing trial, but then when you extubate them to ambient pressure, the patient fails and may need to be reintubated. So the best weaning parameter is a spontaneous breathing trial. So if you like weaning parameters, you can say, okay, I'm going to use the spontaneous breathing trial as my weaning parameter, because the best way of identifying when the patient is ready to breathe without the ventilator is to take away the ventilator and see how well the patient breathes. And by the way, it's been shown that this is really quite safe if the patient is monitored closely by a respiratory therapist and a nurse. If you initiate the spontaneous breathing trial and the patient fails, they become tachypnic, diaphoretic, tachycardic, and so forth, well, then you just reinstitute respiratory support. So really quite safe. There are a number of potential ventilator approaches that might be taken to weaning. And the point that I want to make here is that these have a low level of evidence. So I have not used these in my own practice, essentially, because the evidence is not very strong. So beware of new ventilator approaches to weaning, and make sure that you identify that there is sufficient evidence for those new ventilator approaches before you immediately incorporate them into your practice. So that's, again, sort of less is more. And I think we need to beware of the myth of minimal ventilator settings, as was nicely discussed in an editorial by Martin Tobin a few years ago. And we want to get away from the whole idea of weaning and minimal ventilator settings and so forth. The idea should be, not the idea, the practice should be. The practice should be that we wake up our patients, we do a spontaneous breathing trial. The spontaneous breathing trial should take away the respiratory support. If the patient tolerates that, then to consider promptly extubating that patient. Now, this is something that we can incorporate nicely into a protocol. So this is a schema that Neil McIntyre and I published a few years ago in an editorial, which essentially says if our patient is on full or partial ventilatory support, we should aggressively treat the underlying disease process. We should then stop the sedation, spontaneous awakening trial. If that fails, well, then we add back typically half of the previous level of sedation, and then we come back the next day and we try again. If the patient tolerates stopping the sedation, then we do a spontaneous breathing trial. If the patient fails the spontaneous breathing trial, then we put the patient back on support, try to figure out what caused the failure, what we can do to address that, so we can come back the next day and go down through this algorithm and end up with extubation. If the patient has a successful spontaneous breathing trial, then we should evaluate the patient for extubation. And if you look at this algorithm, you might say, well, that would lend itself very well to a protocol, wouldn't you think? And indeed, that does lend itself very well to a protocol. And in fact, now we have a lot of evidence supporting the use of weaning protocols or ventilator liberation protocols. And I would submit to you that these should be the standard of care. We have high-level evidence to support the use of weaning protocols or ventilator liberation protocols implemented by respiratory therapists and nurses at the bedside. In this systematic review and meta-analysis published a few years ago, they found that compared with usual care, the use of weaning protocols can reduce the duration of mechanical ventilation by 25%. That's huge. Weaning time by 78%, and the length of stay in the ICU by 10%. So we have very robust, high-level evidence to support one of the things that we should be doing as respiratory therapists, which is implementing ventilator liberation protocols in the ICU. And again, they should stress the use of spontaneous awakening trials and the use of spontaneous breathing trials. So then my final point to leave you with is on this slide, and that is that many times less is more. And I showed you a number of evidence-based therapies in this presentation, therapies that we as respiratory therapists implement where less is more, and we should first do no harm. So there are a number of examples where less is more in what we do as respiratory therapists. These include things such as non-invasive respiratory support, lung protective ventilation, how much oxygen we administer to our patients, and how we liberate our patients from mechanical ventilation.